This is the Mechanical Care Forum, episode 347 of season 9, and the continuation of our discussion of the value of a mechanical exam within physical medicine and rehabilitation with Dr. Joe Eim, an initiative called Exercises Medicine, distilling down what it means to educate patients properly from a mechanical angle and more this week on MCF.
I'm Jason Ward, and this is the Mechanical Care Forum. Think of it as your weekly dose of inspiration, information, and entertainment, where we interview leading clinicians, instructors, researchers, authors, practice owners, and more, all for the purpose of sharing experience for improved patient care. This episode of the Mechanical Care Forum is free, and it's brought to you by myself and a small team to help you along your journey. If you'd like to show your support, you can do so by making a small donation or even a big fat one. We'll gladly take any amount, and we'll use it wisely to continue to produce this great content. Go to mechanicalcareforum.com to show your support.
Hey everyone, and welcome back for part 2 with Dr. Eim. More great conversation and perspective from a physical medicine and rehabilitation physician on how he sees value and uses the principles within a proper mechanical exam to assess and educate and treat his patients. That conversation coming up in just a bit, but first a quick reminder to sign up for my free weekly email update, which will give you notification of new episodes. It'll keep you up to date on my other projects and resources to help you continue to grow professionally. You can sign up at mechanicalcareforum.com. And by the way, you may remember me mentioning our giveaway of a dynamic cervical spine model from Dynamic Disc Designs for one lucky listener who signed up for my email updates or who liked and commented on a post from episode 344 or 345. And I'm happy to share that Mr. Joey Downing is the winner. Joey, reach out to me and we'll get your information to get that spine model on its way to you. Congrats. Keep an ear out for more coming opportunities like this. And thanks to Jerome and our friends at Dynamic Disc Designs for this generous offer. Check them out at dynamicdiscdesigns.com. So already this year we've focused on the lateral shift with John Weinberg, a diplomat and McKinsey Institute USA instructor who's seen a fairly large number of shifted patients due to a specific doctor referring these to him. Then we shifted our attention. Did you see what I did there? Shifted our attention? We shifted our focus to a mechanically unresponsive radicular syndrome with Hank Templeman. Hank works in a clinic where some of the research on non-responsive patients initially, without a directional preference, who received an epidural injection then showed to respond favorably and show directional preference. Next up, we connected with Cora Aitona and Gaurav Kikapur, presenting a couple of patients classified as contractile dysfunction and successfully managed through to a good outcome. And most recently, we focused on effective goal setting with Steen Olsen, who's done a master's in positive psychology and who, with his partner, has refined their intake and patient feedback process to monitor their patients' function, pain, and well-being, an area he's persuaded is essential to measure. The point is, month after month, we're connecting with experts and tackling important and relevant topics to gain practical insights and ultimately to fill in those gaps and supplement our formal courses and conferences. Whether you're practicing all alone or in charge of a team of clinicians and could use some help with content that will improve your clinic's care, come join us and subscribe to Case Conversations. And this season, Season 2 of Inside the Science, we've highlighted lateral shift case reports, a reliability of detection of lateral shift observational study, systematic reviews on effectiveness of medication of lumbar radicular syndrome, and effectiveness of epidural injections for sciatica, an association of mechanical versus meniscal symptoms and pathology, a case series on large disc herniations and their rapid reduction, a paper on whether patients remember their therapist's advice, the level of McKinsey education and association of function outcomes, pain, and utilization paper. Just some of what we highlighted this second season of this newer podcast. Subscribers have covered now 32 papers just since August of this past year, and not only been exposed to a summary of the paper, but heard from the authors themselves, and benefited from their inside scoop, as well as receiving a PDF and infographic to each study to use for patient education, marketing, or peer discussion. The point of Inside the Science is that with tens of thousands of papers coming out every month, a busy lifestyle, and plenty of distractions, we know we should be keeping up with the literature and following the evidence, but the reality is you may not be keeping up as well as you should, and we can help. Make the decision to do better, and if Inside the Science could be the difference, come join us and subscribe. You'll find both of these resources at mechanicalcareforum.com. Okay, so we heard from Dr. Eim last week about his work and how it's been influenced in a positive way through thinking and incorporating mechanical assessment. So we'll continue our discussion for part 2 with Dr. Joe Eim. Enjoy. We provide education to patients, and so do you. I'm saying we from a clinician in a general sense. Provide education. We provide you provide medications. We don't do that. You can provide an epidural injection you just mentioned, and you can provide and we provide prescription of exercise. What of those are most important for patients, do you think?
I understand you're trying to distill it down to, where's the magic, right? I guess what I would say, speaking very broadly, I would say exercise is and of course, I'm a huge component and proponent of exercise. So very briefly, my undergraduate is exercise physiology, and I started med school at 30. I was a personal trainer before I went to med school. So I'm already coming into that with an exercise bias. And since I've now been practicing, I have some responsibilities in one of the exercises medicine clinical care committees through American College of Sports Medicine. So I'm saying my answer with that preference. So I'm already telling you how biased I am towards exercise. So to answer your question, I would say exercise is number one because of so many things that it does. And when I use the word exercise, I suppose I probably should broaden that to physical activity, because more recently, you may have seen some of these studies. They're starting to look at step counts and spine pain. So step counts don't imply exercise. Step counts just imply movement. As you already know, most Americans don't meet the requirements for physical activity and health. So most of the people getting steps are not getting them through a lot of exercise. So I want to just sort of change the focus of what you were asking me about and say activity, because being statically still, I think, is probably one of the biggest problems. And I don't even want to say statically still and unhealthy, right? I don't even mean you don't have to have high blood pressure. You don't have to be obese. You don't have to be diabetic. Just being still in the way that we tend to be still at this time in our existence is a problem. And I think it's probably one of the most common things that causes the pain that I see in the spine. So I think activity and exercise is number one. A more specific question is, what should that exercise be? And then that gets a little bit more complicated. And I'll just give one example because you're asking about exercise. So the challenge is, right, I've got this patient who comes in to see me and says, hey, I had back pain a year ago. It's about 80% better. And I'm doing my home exercise program, which really helps. And I say, well, how long does it take for you to do that exercise program? And they say, well, it takes me 30 minutes a day to do that exercise program. And I think to myself, okay, that there's nothing really wrong with that. But then you start playing the odds and you say, well, if you're doing 30 minutes of that, the chances that you're getting the recommendations for physical activity and health for all Americans, all adult Americans, is low, right? Because if you got to give up that 30 minutes for that, you're not going to do other stuff more likely. So to me, this discussion about activity and exercise is a broad one. And I don't pretend that I have the right answers, but in that particular patient example, that's what I'm going to do. I'm going to sit there and say, do we need all 30 minutes that are focused only on your spine, or can we pare that down and then sort of push you more into, well, are you still sitting 8 hours a day? Or are you getting any aerobic activity in? Are you even getting a bunch of short walks a day? So that's sort of, and that's probably still fairly brief, but that's sort of how I'm thinking through exercise and physical activity. Because of course, the literature has this very well circumscribed, right? You have, let's start back pain patients in a walking program, 30 minutes a day, 5 days a week. Well, that works. Great. Let's put them in core strengthening. That's another type of exercises. Well, that seems to work. Well, let's put them into high intensity interval training. Well, that certainly helps some of them. So it's sort of like, well, what do I focus on, right? And that is a question that I get from some patients is, well, I've got these 20 sheets in front of me that I've gotten from 3 therapists over the last 10 years. Which one of these things do I do, right? So it does get us back to this mechanical discussion, however, because that's what I end up being focused on. So if this person's in front of me and they're like, this program takes me a while, and I say, well, what are you doing for aerobic activity, or what are you doing for walking? And they say, well, I take a 30-minute walk maybe twice a week. I'm already on that. I'm going to be shifting away from several sheets on the spine and more so on movement in general and get them out of prolonged static positions. I'll still talk about their home exercise program for their spine, and I probably will come up, I don't want to make it sound like I'm selling a product, but I would probably come up with 2 to 5 exercises. I mean, it could be more or less, but I'll probably come up with roughly 2 to 5 so that I know that that's manageable. And so I know it's not time consuming, and then they can get these other forms of activity, and that likely will be very helpful over the short and long term.
Mm-hmm. I want to come back to that topic of incorporating more function, since that is the focus of a PM&R doctor, that as you've kind of clarified. But first, can you talk a little bit about that exercises medicine effort?
Sure. So the American College of Sports Medicine came up with something called Exercises Medicine in 2007. And the goal of that initiative was to get all providers discussing patients' physical activity level and then promoting what we know is a beneficial level of activity in those patients that we see. And certain hospital systems, I'll give you a couple of examples. One is Kaiser in California. Another is Intermountain in Utah. One of my colleagues, Cindy Lin at University of Washington, is doing this. I am just starting to try to do this. They have something called the Physical Activity Vital Sign. So the goal is to ask people 2 basic questions to discern what their activity is. But I'm off on a little bit of a tangent. So the initiative is really just to be able to say, hey, let's educate people on what the recommendations are, because so many providers don't know what they are, number one. And I'll tell you from literature, from experience giving lectures on this topic, a good number of physicians and physical therapists don't achieve the recommendations, because there's common times I'll be in a room and I'll say, how many of you have done these recommendations for the last 4 weeks? So I'm not even asking them, are you doing it chronically, just the last month? And I would say it's either a small majority or sort of a small to moderate sized minority. And so that initiative is really just to get activity and exercise to be part of the regular clinic visit, but also to teach providers and healthcare providers what should be done and what is a way to promote that. And there's a website called Exercises Medicine that has the Healthcare Providers Action Guide in there that gives the provider lots of ways to incorporate this into their day-to-day routine. And I use one of their prescription sheets that allows me to check boxes like 5,000 steps a day, 7,500 steps a day, 30 minutes of walking, light activity, moderate activity, that sort of thing. And within that sheet are the 2 recommendations for all adults about what I'll call aerobic activity, but really it's moderate to vigorous physical activity, 30 minutes, 5 days a week, and then resistance exercise twice a week.
How successful, when you recommend that for a patient, are you with creating behavior change?
Well, it's a really good question. And you know how hard it is to answer that, because I've learned really, really well not to base, how do I put it? I've learned really well to be careful about how I base my experience on a broader scale, because I know I have a lot of built-in biases. I know I have a lot of built-in beliefs. And I also know that I can talk patients into stuff. And I also know that patients want to make me happy, right? They don't want to come back and say that what I suggested sucks and doesn't work. They want to be able to say, hey, what you said was really good. So I'm saying all that as I answer your question, because I'm fully aware that I can't really discern that with my discussions with my own patients. That being said, there's some literature out there that says if a physician or a clinician spends a few minutes discussing these things with a patient, that you're likely to bump them up 1 notch on the decision-making scale. So they might go from a pre-contemplator to a contemplator or something like that. So that there does seem to be some efficacy in having that discussion. The other thing, since you're nicely asking me about all this stuff, the other thing is that, interestingly or not, physicians or clinicians who do the recommendations are more likely to discuss it. So in the last few years, I've started to say, because I actually had a question about this at one talk I gave, and they said, well, what do you think is the best way to promote this if you're a physician? And I said, meet the recommendations, right? Because if you meet the recommendations, you're more likely to discuss it, which I suppose is intuitive, right? You're more likely to discuss things that you like and you find benefit from. So from your question, it certainly does happen sometimes, but admittedly, in the last few years, I've sort of stepped back and become more focused on step counts. Now, that doesn't mean I don't ever talk about exercise, but again, I find it hard just to get patients to do 5 days a week of 30 minutes of moderate activity if they're not doing it. Now, plenty of them are doing it. So it's not like nobody's doing it. Plenty of my patients come in and some of them are having pain because of their activity level, but a good number of people are not doing anything except for casual walking. And so in those folks, it's a more nuanced discussion. I may focus more on step counts because in the last 5 years or so, there's been a lot of studies on step counts and health outcomes. And if they get past that, then I will sort of focus more on what we would call traditional exercise. So again, I probably have changed some people's behavior. I don't really have a good sense of how often that's happening.
Yeah, it's a challenge for anyone. There's a broad spectrum of responses from patients for a lot of different reasons, but I just thought I'd offer the question since sometimes that's a challenge when we're trying to take someone and we can see what they need to do. They can even see it, but they just can't get themselves to do it. So I appreciate your thoughts on that. Your focus within PM&R, you had mentioned, was on function. How does that different than a neurosurgeon or neurologist or who's seeing a patient with some kind of peripheral nerve issue, or an orthopedist who's seeing a patient with osteoarthritis of the knee and a knee complaint, or a general practitioner who's seeing a patient with some first-time onset of back pain? Or at least in your mind, how is it different?
Well, I know you're not overtly trying to throw me under the bus, but I have to be careful about how I talk about my colleagues. I don't pretend to really know all the stuff that gets discussed among specialties. So what I'm going to discuss are some of the things that comes up when I talk with patients. Let's just pick for a second the spine surgeon and a discussion about a spine problem. I commonly will tell patients that I'm sending you to a surgeon to have a surgical discussion, because I've had some of my patients ask me, they'll say, well, hey, we haven't quite solved my back problem. I'm going to go see the surgeon. And I'll say, what are you looking to get from that appointment, especially if I see that this is not really a clear surgical problem. For example, back pain, right? They have back pain, they have no radicular pain, and fusion, while certainly an option, I'm usually not sending people for fusions unless they're miserable. And so I do get patients that are not miserable. They're uncomfortable, but they're definitely not miserable. And it's not even clear that fusion would be a solution for them if they have multi-level changes. So I might ask them, well, why are you going there? So, well, they're an expert in the spine. And I'll say, well, there's a chance they're going to have a discussion with you about non-operative management, but I'll tell you, they're probably going to be mostly focused on surgery. So that's one, I'd say, potential difference. And since you mentioned some comparing and contrasting, since we focus on function, depending on the surgeon, that may not happen very much. Now, there are some surgeons that do that. So that's why I say I don't want to be black and white about it. But no, chances are the surgeon's going to be like, yeah, what I could offer you is a fusion, but I wouldn't do a fusion. And you're welcome to do shots and physical therapy if you want to. That I have a feeling that's really brief, but I have a feeling that's sort of the gist of a lot of conversations. I would find it really interesting if this happens, but I don't expect that a surgeon would say, well, when you sit like you do, your spine is in flexion. And since you're worse with sitting, I think we need to figure out how to get you out of flexion. My suspicion is that's probably not going to be something they'll have a lengthy conversation about. So for that scenario, that's some of the situations I think there. So thinking about, you brought up osteoarthritis. My take on the osteoarthritis is that surgeons are commonly looking at an x-ray and someone's function in their exam and saying, yeah, I think we need to do a knee replacement and maybe do an injection, depending on their level of pain and the level of severity of osteoarthritis. My suspicion is they're not having a detailed discussion about what strength training they could do to try to improve the strength in their knees and possibly also improve their pain. Less likely, but certainly possible, they may not be having a discussion about how much sitting that the patient is doing and how maybe starting a specific type of either step count goal or walking program might be helpful to them. And I think all that makes sense. I mean, I'm not going to have a detailed discussion about how I'm going to put screws in the spine, how long the recovery is going to take specifically, what percentage of people get a dural leak or an infection. That's no help to me. I don't need to know that information. So I think I would probably be, or somebody like me would be the kind of person to really help maximize somebody's non-operative management, but also hopefully give this person some tools to minimize future problems depending on what they want to do and what they want to change.
Yeah, and I was certainly not asking you to throw your colleagues under the bus, but I could see someone out there thinking, well,
a PM&R doctor focuses on function. Isn't that what all clinicians who see patients that are in pain and therefore are having challenges with the daily needs and desires of what we all want to do? So I appreciate you explaining that. And that does make certainly good sense.
I'm going to throw in one other thought.
Please do.
My impression is this. Interestingly or not, there are surgeons, certainly at Northwestern, that are learning about McKenzie. Now, I don't know exactly what they know about McKenzie, but it's in their note, and they'll refer patients to therapists who are McKenzie certified. So it's interesting to see that happen, because I'm going to guess that's not happening in a lot of situations. But I have a feeling, again, given how much of a presence there is for that sort of approach, it's really interesting to see surgeons start prescribing physical therapy. In other words, just as an example, there's a surgeon who is a hip and knee replacement surgeon who refers people with back pain to a McKenzie physical therapist. I think that situation would be really uncommon in general. That being said, the other thing I wanted to add was the challenge, of course, is what do we call a failure for physical activity? And again, I think that gets into possibly some of the differences between the different type of clinical specialties, because it's not uncommon that I would see, and a primary care physician that I know really well, they'll send me a patient that, quote, failed physical therapy. And realistically, when I talk through with the patient what the therapy was, and while there aren't a lot of therapists like this in Chicago, there are still some therapists that will do your sort of standard cat-camel, knees to chest, put your knees up and roll side to side, bridges and clamshells, and that's the treatment of their low back pain. Now, granted, that's going to help some, but there's going to be a lot that it won't. And so that, again, probably gets into the subspecialty focus compared to a primary care physician who is not necessarily focused in the same way. And therein lies some of the challenge when it comes to surgical decision-making, because you could say that person failed physical therapy, and so you're going to offer them surgery, but what is that physical therapy? And I'm sure you, as well as the listeners on this podcast, know plenty of the surgical articles on back pain don't describe the physical therapy protocol. So we don't even know exactly what they didn't do well with. And so I would say that might be, in addition to what I've said, that might be some of the major ways that somebody in my situation who sees a lot of spine from a non-operative perspective would address that problem. The problem of, hey, I didn't really respond to physical therapy. Well, what does that really mean? And then trying to figure out, why did you not respond? And not necessarily jump to, well, this is much worse, or we need an MRI, or you need to have surgery, or we need to do an injection. Let's just think through why there was no response there.
Mm-hmm, mm-hmm. Yeah, thanks for adding that in. Dr. Eim, you mentioned that you commonly cross paths right there outside of your area where you're working. You're crossing paths with physical therapists and those that are mechanically trained. What value is there for the patient when you have one center where there's multiple disciplines who are right there together treating that patient, versus those situations where a lot of listeners are probably in, where they work in their little silo and the general practitioner is in his or her silo and the surgeon is in their silo? And you can see where I'm going with this. Can you just talk about that for a moment?
Probably the main thing is accessibility. So if either I have a patient that's struggling or the physical therapist has a patient that's struggling, it's very common that they will either email me or they will just come talk to me, because, as I mentioned, I'm about 10 feet away from the physical therapy office area where they're documenting their notes. So that makes it real simple. And sometimes it's really straightforward. They might come say, hey, they're having this problem, and for whatever reason, maybe my note didn't say something, or we just decided to brainstorm together, and we may come up with, well, let's do this. And that allows for that to happen fluidly, easily, and with minimal interruption. Now, granted, every so often, the therapists that I've come to refer to in the area, they will email me as well. That happens less frequently. One of the therapists does email me with some regularity, but a number of them email me only in rare cases, and some don't email me at all. So in other words, to communicate with them by phone would be less easy. It's certainly doable, and sometimes it happens, but it'd be less easy than somebody literally just walking 10 steps and we talk for 2 to 3 minutes and then they walk away. That's a lot easier and a lot more predictable. So to have them here in the clinic, that makes those sorts of conversations easy. Similarly, if I just want to tweak one thing in their therapy, I can easily just walk over to them and say, hey, I just told them we're going to do this. Let's just do that. And then that makes that easy to do. And there's how should I say it? There's a certain level of trust that gets developed over time so that it's not me talking to a stranger, meaning the physical therapist, me talking to a stranger and saying, hey, I want to do this. Now the therapist has to decide, am I just going to do what they say? Or do we need to have a conversation? Do we need to sort of feel each other out? So those are some of the more difficult things, let's say a random therapist in the community. But if it's one of the therapists I know, no, we'll not uncommonly problem solve together if we run into a situation. And that collaboration still works pretty well, even if it's just through email. But having them in the building makes that conversation, for one thing, it makes them occur a lot more frequently. I'm probably talking, when I sit in my office, if I'm in my office for more than an hour or two, I'd say at least 1 out of 3 or 4 times that I'm in there that long, somebody's coming to talk to me about something. So I talk to physical therapists in the building pretty frequently.
Mm-hmm. The other aspect that you are involved with is teaching in medical college. We discuss in our circles about where we can do better of getting this message out about an MDT approach and how we feel like significant value to patients in general. We think, do we go to the public? We think, do we go to the schools? Do we go to our peers or our colleagues that work in other disciplines to educate them on these principles? How much is there that you are teaching, including, I guess, in your teaching on some kind of MDT principle, maybe those subcategories that you had mentioned from that study before? And how much, I guess, has that changed in the past 10, 15 years from what you were teaching maybe before?
The primary teaching I'm doing on a mechanical approach to a spine problem is with residents and fellows. So we have 2 sports fellows a year, and then we have a relatively large residency program. While those sort of discussions may come up with a physical therapist here and there, or may come up in medical school, the majority of those conversations are occurring in clinic when we're seeing patients. So just wanted to give a frame of reference of when that sort of education is happening. I certainly have given some lectures on this, but I mean, as far as the bulk of the teaching, it's really one-on-one with trainees, and most of those are residents and fellows. In that scenario, I guess I would say that what I've taught has become more and more nuanced, and you've heard me use that language in our discussion today, meaning that as much as I like the idea of subcategorizing patients' back problems, or any problem for that matter, but we're talking mostly about spine, I really try not to say this is a McKenzie approach per se. I'm really sort of saying this is a mechanical approach, and it's not just about a physical therapy program. It's about the stresses through the spine that are causing pain. And then depending on the individual who's in front of me, I might go very simply and say, well, why don't you, I'll give them a copy of that Charles and Fritz 2006 JOSVT article, or if they want more details, then I'll get into other things like, well, what does your spine do when you sit? What does it do when you stand? What does it do when you walk? And what are the pressures through the disc based on some of the things we know about the disc pressures in different positions? So that's pretty brief, but that just gives you a broad idea of what I'm looking at. I'll also, depending on the scenario, of course, I'll bring up how core strengthening may either be the predominant thing or maybe a complementary aspect of treating a spine problem. And then, of course, one of the main things when you have somebody who has relatively short-term back pain in front of you is the idea that McKenzie can change that pain sometimes in hours or days, whereas core strengthening, in my mind anyway, core strengthening is often a faith-based decision. It's not based on necessarily who's in front of you specifically all the time. It's based on what does the literature show, because people are not going to get strong in a week or two. They're going to get strong over anywhere from 2 to maybe even several months. And so that person's not likely to say, oh, that clearly made a difference. Sometimes you can say that, but I mean, often it's more difficult, which doesn't mean I don't prescribe it, but it does change that discussion a little bit with talking with trainees. And I try to get especially the fellows, I try to get them away from just they'll say the plan and they'll say, well, a McKinsey-based program. And so I, as they get more knowledge, I try to push them on that for reasons that you and listeners can probably appreciate, because before I took parts A and B, I didn't fully understand exactly what was going on. And of course, it's a lifelong learning process. So I'm fully aware that I keep learning as I practice longer. But I mean, at that particular stage, before I had taken those courses, which I think I took, I can't remember exactly. Dave might remember because he was my instructor for part A, but I believe it was about 5 or 7 years into practice. And by that point, I had gained some knowledge, but it really changed doing the pre-work before the course and then doing the courses. And so that's what I'll usually push the trainees towards. So it just depends on their level of understanding. I might go real basic and simple, just the concept of subcategorization, or I might get in a lot more detail if they've already been seeing patients with us for several months, just to push them so that they're not so focused on very discrete things. Because I do, not to keep saying this too many times, but I do think it's really important to take this idea of a directional preference and extrapolate it to the entire daily program that a patient does, everything. In some ways, I find it amazing that doing 60 press-ups, which could take, what might that take? That might take, 20 minutes, I guess, over the course of a day. How that actually makes pain better if somebody's sitting for 8 hours a day. I sometimes find it amazing that it does that. And as we know, often it doesn't do it completely, which is why this broader discussion can be helpful.
Yeah. You had mentioned that our development and continually learning is a lifelong, career-long process. And I was just curious, what has you intrigued? What's challenged your biases and your comfort level?
I like that question, but I'm struggling a little bit. The thing that probably challenged me the most, so I have, which we have not talked about this at all, and I don't need to talk about it if we don't want to focus on it. I really like tendinopathy. I've been involved in writing about tendinopathy several times. I've lectured on tendinopathy several times. And just as an example, there was, I got the opportunity to do another article on tendinopathy, and I picked the topic. And the topic was asymptomatic findings in young athletic people of the rotator cuff. Or maybe it was all tendons. Now I'm actually forgetting. It might be any tendons, but the rotator cuff would be one of the more common things to study in that scenario. And I was really surprised to see, not a lot of studies, but see a few studies looking at people in their 20s with rotator cuff tears that were asymptomatic, that were playing high-level sports. That surprised me. I would say that really challenged me, because prior to that time, most of the literature suggests that rotator cuff tears can come middle-aged or later. Well, there are exceptions, of course. You can get traumatic and things like that, or really severe genetic issues where they're just going to get tendinopathy all over the place or other things. But sort of the average healthy person who's not doing a lot of overtraining, you're not going to see tears very often in under 40, was what I had learned prior to that article. Now, granted, since that article, it's not like I'm seeing a bunch of 25, 35-year-olds with rotator cuff tears, but I do look at it a little bit differently as a result of that and really appreciate the difference between that. I would say that that's one thing that challenged my bias. I'll give one other example and then we can move on to whatever. But the step count issue has really challenged me. When I was a personal trainer, and you may remember this as well, although I don't know how old you are, so I'm just making a guess you might remember this. But in 1996, in JAMA, that's when the CDC and ACSM released the first real major recommendations for physical activity and health. And that's when they really announced the 5 days per week of 30 minutes. Prior to that time, it was 75 minutes a week, so 25 minutes 3 times a week of vigorous activity. And that's when they added the nuance of the moderate. And it was also the Surgeon General report that came out around that same time as well. And even since then, I was very focused on exercise, right? The sort of a formal thing. You take time out, you do it. But in the last five, maybe 10 years, there have been some really large studies showing that light intensity physical activity, if there are enough steps that somebody gets, can impart some decent health benefits. I still think that the literature is showing pretty clearly that more vigorous exercise imparts greater benefits overall, but plenty of studies show really good outcomes in people who are not necessarily meeting the current guidelines for physical activity and health, but are accumulating enough steps that they're very healthy because of the steps they take, even though they're not formally exercise.
Mm-hmm.
two areas, and certainly not too far off topic, because tendinopathies we understand, quite well. I've had Joe Cook on the podcast here.
Okay.
Yeah. And so we understand quite well that it's a management of load to rehabilitate those. So it certainly fits within the context of our discussion today. But and then the step count, that's a new area for me. I'll have to look into that. Maybe I'll share some of the studies or whatever that you might suggest for listeners. They can find those in the show notes. And I realize we've jumped around a little bit into several different areas, and I appreciate you being willing to do that and give us your thoughts. If we've come full circle and you had to boil it down for your advice for a resident in PM&R in viewing best care for patients, meeting the needs for those patients, the common patient that you guys might see, what's your advice for a clinician a little earlier on in terms of developing themselves and giving best care from maybe a mechanical minded type of slant?
Yeah, I guess just trying to distill it down to some basic points. I think if I'm really trying to stay somewhat broad, because it really is, as you know, every patient really is different. I mean, they really are. There's something about them that always makes them just slightly different than the one before. Even if the two of them sit there with 3 out of 10 back pain, that's worse with sitting and better with walking. There's always still something about them that's a little different. So thinking across broad ideas, one, probably trying to give this person in front of me the idea of what is the spine going through when it's not moving, because that is often a precipitator for pain. And what does movement do for a person like that? So maybe that's too general for what you're asking, but that is often what I'm trying to get to the person who, I'll give you an example. Plenty of our residents go into traumatic brain injury. And while they're going to see some back pain and some neck pain, it's definitely not going to be their focus. And so for that person, I'm usually telling them about that article about subcategorization. I'm usually telling them, hey, if you're in the middle of whatever, Iowa, and you don't really know what therapists see back pain, but you have somebody in front of you and you want to try to be helpful, use the McKenzie website, which I'm not trying to plug that. I just mean there are very few resources that you can use like that to pick out a spine therapist or practitioner, because chiropractors are certified. Some of them are certified as well. So it's often the subcategorization, a discussion of static positions. I mean, certainly talking about dynamic things as well, but it's often the static flexion that can be a problem for people. And then talking about how movement, walking, exercise, physical therapy, things like that can be facilitating less pain and lower chance of having a problem with the spine.
Very good. Well, I appreciate, Dr. Im, you being willing to give us a bit of your story, the evolution of your career and how it's been impacted with some of these mechanical principles, your discussion on exercise medicine, and of course your focus on function. And we really appreciate you being willing to take time out of your schedule to join the podcast today.
It's my pleasure. Thanks for having me, Jason. Really appreciate it.
And there you go with episode 347. Sincere thanks to Dr. Im for sharing your views. Exercise is Medicine, a global health initiative to make physical activity, assessment, and promotion a standard in clinical care. Sounds like a positive effort for sure. We'll leave the link for you in the show notes of this episode if you'd like to learn more about that. Moving your patients one notch on the decision-making scale. Persuading people to increase their activity level and creating behavior change. It can be a challenge, but we do have an influence over our patients, and as Dr. Im shared, we're more likely to promote physical activity guidelines if we're doing them ourselves. Accessibility with practitioners of different disciplines, a benefit Dr. Im has seen very valuable. So do you have a PM&R physician you have a good relationship with? And how have you achieved that? I know some of you have mentioned challenges with having a collegial relationship, one that's reciprocal in referring and joint clinical reasoning and decision-making for the patient. I'd love to hear it if you have success in this area, so leave your experience on the page of this episode. That's mechanicalcareforum.com/podcast/347. And while you're there on my site, of course, don't forget to check out the hundreds of other episodes with guests who have specific expertise, which can help you keep pushing the needle forward in pursuit of bettering your care for your patients. And of course, don't forget our other resources and the free trial period and a money-back guarantee on both Case Conversations and Inside the Science. If you feel a bit isolated and you wish you had access to expert clinicians and true authorities in research, pull the trigger and subscribe to Case Conversations and Inside the Science. Okay, I wish you a great week with your patients this week. Help educate the patient in front of you, as individualized as they deserve. And join me right back here next week for more of sharing experience for improved patient care.
The views and opinions expressed on this podcast are those of the founder and host, Jason Ward, and his guests, and may not be those of the McKinsey Institute International. The content here is independent of the McKinsey Institute International and is not associated with its educational program.